Today we're going to talk a little bit about hip and knee diseases. So we're going to talk about the surgical approach to hip and knee disorders with our very well-trained guest speaker, Dr. Chet Simmons. Dr. Simmons is an orthopedic surgeon. He's a member of the Chester County Orthopedic Group. A lot of people would be happy to know that he is a Bucknell graduate, because I know there are many Bucknell graduates here in Hershey's Mill. Attended Jefferson Medical College and did his residency in orthopedic surgery in the Rothman Institute, which is at Jefferson at the present time, and then went to the New England Baptist Hospital in Boston for a fellowship in total hip and knee replacement. So Chet, we thank you for taking the time to come and discuss this problem with us. I think we should start giving a little bit of a preliminary background and build up to the surgical approach to this, what leads to it and so forth. So could you tell us a little bit about what the main disorders are that affect the hips and knees?
Certainly. That's nice of you to have me today. What we are seeing in orthopedics today is really a big explosion in the incidence of osteoarthritis of the hip and knee, and that's the most common disorder that will affect these joints. Particularly with the baby boomers coming of age and all the activities that they were involved with in their youth, we're seeing a much higher prevalence of arthritis of those joints. There are many other conditions that can affect the hip and knee, but I think osteoarthritis is the most common.
And what are the prevalent symptoms that patients will experience with these primarily?
Well, most of us are familiar with those, but typically the first symptom that people complain of is pain, obviously. There is inflammation of the joint that causes swelling. That leads to stiffness and restriction of movement, and the patients notice difficulties with their activities of daily living, such as getting dressed, putting on their shoes and socks. A lot of patients in the later stages of the disease will develop night pain. They have achy discomfort at night that interferes with their sleep.
Is there anything peculiar, say, to the hip and the knee specifically?
I think with the hip, it can be subtle and it can be confusing. Many patients come to our office saying, I've got a back problem, or my legs aren't working, I have a knee problem, and it turns out to be the hip. The first thing that we often see is loss of rotation of the hip. People can't turn their leg or cross their leg to put on their shoes and socks, and they're not quite sure why that is, and it takes a little bit of examination to get to the bottom of that. With the knee, I think typically patients note swelling, stiffness. They may have mechanical grinding and popping, but the symptoms in both joints are kind of merge together at one point and lead to just pain and restriction of movement.
Now, is there anything that individuals do that aggravates this or makes it worse, or is there anything they can do to make it better?
Well, I think in some cases it is a genetic problem. There's a predisposition to arthritis, and it doesn't matter what you do, you're going to end up with it. We're seeing it particularly in the baby boomer generation. A lot of overuse injuries, people that injured their knee playing sports as a child, and over many years the joint begins to wear out. I think some of the excessive aerobic exercise and running that a lot of the people did in the 80s and 90s is catching up to us as well, and we may have gone overboard in that. So I think there's a genetic predisposition. There's also activities that put the joints at risk.
There's a lot of tennis players here at Hershey's Mill, and is this stopping and starting on a tennis court very hard on the knees?
I think it is.
Yeah.
Typically, I don't tell people to stop the activities that they enjoy, but using a little bit of common sense can be helpful.
Yeah. And is there anything they should do in particular to, like the shoes that they wear or something like that? Is there anything they can do to prevent this or make it better from a mechanical point of view?
Well, I'm not sure that the shoe wear has been shown to make much of a difference, unfortunately. I think in general we tell people to try and keep their weight down to an appropriate level. Every pound that you lose is 2.5 pounds of pressure off a joint when you're standing on one leg because of the magnification of the body. So losing weight can really help. I think maintaining flexibility when people start to have pain, they stop using the joint, and the joint becomes tighter and tighter, and it dysfunctions. So maintaining the range of motion, I think, is important. There are lots of supplements and dietary things out there, like the glucosamine, most of which do not have a lot of science behind them, and I'm not real high on recommending them to most patients.
This was leading into what I was going to ask you. What are the primary conservative measures for treatment that you start with?
Well, I should mention, since we're at Hershey's Mill, that the most popular thing I hear of from my Hershey's Mill patients, and some of the audience members may recognize this, are the gin-soaked raisins. I've been told by a number of Hershey's Mill patients that if you have 9 gin-soaked raisins every morning, that it will ward off the symptoms of arthritis. So I don't know of any scientific data behind that, but it's something to consider.
You soak them overnight? Is that
That's what I understand. Everyone has a jar of these on their kitchen counter here, from what I've been told.
Well, I haven't heard that one. That's very interesting. Is there any particular kind of gin that should be used?
No, I've been told they must be yellow raisins,
Yellow
not the
raisins.
brown raisins.
So the gin doesn't make any difference. Okay, that's pretty good. What about physical therapy? And this is commonly said to people who have joint pain that they should start physical therapy. Of course, the limitations of the pain may interfere, but could you address that a little bit?
I agree. I think there is a role for physical therapy, particularly in the patient that has developed stiffness and loss of motion. Some physical therapy treatments and exercise actually exacerbate the condition and make it worse. So people with arthritis can only tolerate so much exercise.
I've heard it said that swimming is a better form of physical therapy for arthritis in general.
Absolutely. I think that's the best therapy out there, any type of water exercise.
Now, what about the use of anti-inflammatory drugs? This is something that is very popular and has its problems. So could you address that a little bit for us?
The anti-inflammatories like ibuprofen, naproxen, Aleve, Advil, they go on and on as far as the names. They all work about the same way, and they can be effective in limiting pain and swelling, but they do have significant side effects, particularly in older folks. We worry about ulceration of the stomach, kidney failure, so they have to be used in moderation.
Is there any one in particular that's better than, or safer or better than the other in your experience?
You know, I really don't think there are. There are many, many different drugs, and as you know as a physician, the more drugs there are to treat a problem, the less effective any of them are.
Especially with arthritis.
But you may be familiar with the special anti-inflammatories like Celebrex, which are designed for those people who have ulceration or acid reflux problems. But Celebrex really does not work any more effectively than ibuprofen or the generic brands.
When you're prescribing these for people, and let's assume that they can take them without any problem, what length of time would you say would be reasonable to determine whether or not they're effective or not?
I would think within a couple of weeks, patients should know the difference. And if they're not getting a good benefit from it within 2 weeks, then it's probably not worth continuing.
Okay. Now, I was going to ask you about the visco supplementation, but we gather that. Could you just explain what they're trying to do with that so people understand why you feel there are certain questions about it?
Yeah. Well, this visco supplementation is a lubricating medication that we use in the knee joint. It's injected into the knee much like a cortisone shot, but it's a slippery substance that helps to lubricate the joint and protect the remaining cartilage. It's actually a natural substance, hyaluronic acid, which is found in joints, and a way to synthesize this has been determined so we can get a purified form. And patients typically will get 3 injections about a week apart, and it can last for 6-8 months at a time, and then it can be repeated if it wears off. And it has very few, if any, side effects. I tell folks it does not cure the arthritis. It takes the pain from a 6 out of 10, typically down to a 3 out of 10. So it can be a very helpful adjunct in patients with early arthritis.
So it's really a delaying tactic.
It's a delaying tactic, but a worthwhile one because it's so safe.
Good, that's good. Now you mentioned too, and this is always a question about the injection of steroids directly into the joints. Could you address that, when it's indicated, what the contraindications would be, and what the possible adverse effects would be?
Right. And by steroids, we typically mean cortisone. That's what folks, the lay people, consider. Cortisone is really an anti-inflammatory medicine. It's like putting Motrin or Advil right into the joint. And it's best for an acute flare-up of arthritis. It's not a good long-term management strategy because with repeated injections of cortisone, it can actually damage the joint or hurt the cartilage. So we use them judiciously for patients who've had a flare-up.
Is there any real contraindication to the use of these?
It can affect the blood sugar in diabetics. As an endocrinologist, you would know that, so we're very careful about...
I asked you the question.
We're very careful not to upset people's blood sugars if we can.
Okay. The orthopedic surgeons are always my favorites when it comes to injections. Now, when these conservative measures fail, what's the usual next recommendation?
Well, with the hip, there aren't too many other simple solutions. Injection of the hip joint is difficult to do and not very effective. And we don't have a real minimally invasive surgery for the hip. And ultimately, patients that have severe pain elect to go ahead with a hip replacement surgery. With the knee, we can sometimes buy some time by doing an arthroscopy, a minimally invasive outpatient surgery or scope, where we can clean up debris, remove pieces of cartilage that are irritating the joint, and again, buy some time for patients.
In those arthroscopic procedures, do you have I guess, a length of time that you could judge one of these is going to last, or does that vary from person to person?
It really varies on the stage of the disease, and it's not appropriate for a severely arthritic knee. It just does not help. With the early stages, if there are mechanical symptoms like popping and catching, we can clean up the debris and it can buy some time.
Right. Now, I'm sure you're used to this question. Dr. Simmons, when will I know when I need a joint replaced?
Yeah, I get that question about 10 times a day in my office. And the first thing I tell people is that this is not cancer we're dealing with. I never twist anybody's arm to have a replacement of a joint. Most people know when they're not willing to put up with it anymore. They've had appropriate conservative treatment. They continue to have pain. They're unable to exercise. They can't make it through the market. They typically start to have that achy discomfort at night that wakes them up from their sleep. And then they realize, I don't want to live with this any longer.
Yeah, and these folks are generally really ready, aren't they, psychologically, to have this done? That's the big issue.
Yes, I like people to make that decision themselves and not push them into it.
That's good. What we're going to do is kind of end this session, which was a session to build you up and give you information as to just exactly what the background to arthritis is, what can be done for it, what can't be done for it, and what then can be done as what we call invasive procedures. We try to be as conservative as possible, but sometimes it fails. So the next session is going to be dedicated to joint replacement. And we'll talk a little bit about hip replacement and then knee replacement and some of the other newer things that are coming along. And we'll be happy to go into detail with these so you folks will understand what's available and what isn't available. So I'll ask you to stay tuned. We'll be back in a few minutes. So with Dr. Simmons again, and stay tuned for the next session. Welcome back to the medical report. Our guest speaker is Dr. Chet Simmons, an orthopedic surgeon from Chester County Hospital and the Chester County Orthopedic Group. This second segment is going to be dedicated to hip and replacement and knee replacement. And so with that introduction, we'll begin and ask Dr. Simmons to talk a little bit about total hip replacement.
Well, hip replacement is really one of the most successful operations that's out there. The statistics show that patient satisfaction and improvement in their function is really well proven. When the hip joint wears out, basically the ball and socket have no more lubrication and they're rubbing bone against bone. When we do a replacement, the procedure is to insert a prosthesis, a new ball and socket. And the way we do that is to remove the damaged ball and then insert a prosthesis. And on this model I can show a hip joint, and in the femur bone there normally would be a ball here that articulates with the socket. So in the procedure, an incision is made on the side of the hip typically, the ball is removed, and then a stem is inserted that's made of titanium typically. It has a rough surface on which the bone will actually grow and anchor the prosthesis down the road. And the prosthesis is fitted into the bone cavity very tightly, and then it anchors itself biologically. And we can put various size and shape hip balls on top. The socket is also a metal socket that is fitted into the pelvis and has a bearing surface, typically of polyethylene plastic. And when those are put together, a smooth gliding joint is restored.
Now that is this prosthesis is made out of what? The hip?
The metallic components are made of titanium.
And the ball is?
The ball is typically made of a stainless steel, but it can be made of other materials for certain circumstances.
Okay. Now, in the procedure itself, what is the length of time that most of these procedures take?
In experienced hands, the surgery takes only about an hour, maybe an hour and a half. Patients are typically in the hospital for anywhere from 2 to 3 days. But we get our patients up walking that afternoon or the next morning. So they're moving right away.
So the post-operative recovery period is the next step in the, I guess, the rehabilitation. What do the patients do to try to accelerate that?
Well, in the hospital, we get patients up right away. We feel that moving quickly is important. Typically, they're on a walker or crutches for anywhere from 2 to 4 weeks, and then they use a cane for a month or so for balance. Patients in the hospital are walking the hallway and even climbing stairs slowly, but climbing stairs before they leave the hospital. Many patients can go directly home from the hospital with a visiting nurse or home therapy, but some patients will go to a rehab center for a few days for extra therapy.
Now, people are always interested, of course, in complications and safety and patient safety and so forth. What are some of the things you do for patient safety so that people feel comfortable when they go in for this procedure?
Well, that's a big issue, particularly in joint replacement. The big complications that we want to avoid are infection, of course, and blood clots. Those are two that are unique, not unique, but common with joint replacement. For infection, we're sure to use antibiotics around the time of surgery. We operate in special clean air operating rooms with spacesuits that isolate the surgeon and the surgical team from the patient, so that it cuts down on the amount of bacteria. And we use some type of blood thinner. There are various choices for a period of time after surgery to cut down the risk of blood clots.
So there's a lot of things done to make this as safe as possible, which is a big issue with any surgical procedure, and in particular orthopedics. When someone has a hip replaced, how long is that going to last me?
Well, the old hip replacements traditionally would last anywhere from 15 to 20 years. And the weak link is the polyethylene bearing surface. That's what wears out, much like the tread on a tire. Today, the polyethylene bearing that we have has 90% less wear than it used to. So we're hoping that this is going to last most patients their lifetime. There are certain other circumstances, a very young patient who may be in their 40s, where we will use an advanced bearing surface, such as a ceramic ball like is depicted here, that may have less wear. But we tell most patients it's probably going to last decades at this point.
Is there any slippage or anything of any of these parts frequently or not frequently?
It's unusual. Occasionally a part will come loose or wear out and patients require maintenance surgery. But as we get better and better and the designs improve, that's less and less common.
Now, what are the outcomes in general statistically for hip surgery?
Well, the statistics show that about 90 to 95% of the prostheses will last 15 to 20 years. The complication rates are pretty low. The risk of infection nationally is around 2%, which is a big deal if you're the person that gets it, but it's a fairly unusual condition. The risk of a fatal blood clot is also very low, 1 or 2%. So most patients are very, very happy and avoid major complications.
And these folks have to be sure, for example, their teeth are safe and so forth and all that before they go to surgery, correct?
That's correct. Any potential sources of infection, we try to identify ahead of time. We have patients get a dental checkup to make sure there are no sources of infection.
So all these preoperative clearances have to be done on a regular basis.
And they're important.
Yeah. Well, I think we'll move on now to the knee. And the knee is always a little bit more complex in my mind than the hip, but probably not you.
I think it is a little more complex, and anatomically, yes.
Yeah, okay. Could you tell us a little bit about the procedure that you perform for knee replacement?
Well, a knee replacement is really more of a resurfacing of the joint. Many of my patients have this vision in their mind that we're going to go and chop the knee out and put a mechanical hinge in, and that's not exactly what we do. The prosthesis for a knee is really a cap that goes on the end of the bone of the femur and the tibia, and that gives it a new smooth gliding surface, and in between there's a polyethylene bearing, much like the hip, that acts as the cartilage and cushion in there. And it's done through an incision in the front of the knee. The muscles and ligaments that support the knee are all maintained at the end, so they're still there operating the joint.
Now, is there anything that's different about the surgical preparation and so forth for knee surgery than there is for hip surgery?
The preparation and the actual experience is very similar, and the recovery is very similar. I think what's different about the knee replacement is that it requires a lot more physical therapy and hard work in order to get the knee moving. And if patients aren't willing to do the therapy and endure some discomfort, they end up with a stiff knee and may be unhappy.
Okay. Is there anything peculiar to, say, to the knee prosthesis as opposed to the hip prosthesis as far as outcomes are concerned?
I think the outcomes are pretty similar. The longevity of the prosthesis is similar, and the patient satisfaction numbers are very close.
And tell our viewers a little bit about the recovery period. You mentioned just briefly that it was a little bit longer. What specifically do these folks do in the forms for therapy? What is the process?
I think with the hip patients, the difficulty is moving around, learning to get in and out of bed, climb stairs, but there's not a lot of active therapy to work on the range of motion and so forth at the beginning. With a knee, that range of motion and strengthening starts right away, the first day, because if there's a delay, scar tissue will form and the joint will really stiffen up. And I think patients have to be mentally prepared to work a little harder with a knee replacement in general.
Okay. Now, I think you've covered the total hip replacement and total knee replacement, I think, pretty clearly, and I hope everybody understands exactly how it was done. I'd like to move on to some of the modifications of surgical procedures that you're familiar with. We're talking about we'll first talk about hip resurfacing.
Sure.
Could you explain that a little bit?
Yeah, hip resurfacing is a new procedure in the United States. It's been here for 3 or 4 years. It's been done in Europe for many years before that. And the theory is it may be a little bit more conservative and bone conserving, and it may potentially last longer than a traditional hip replacement. And in this model, you can see the difference between the two. With the hip resurfacing, instead of removing the damaged ball, we just place a small cap, which if I can remove it here, on top. So we shape the end of the femur bone, and then we place this cap and stem on top that makes it smooth again. And what's a little bit different is that the socket prosthesis is all metal. So the joint ends up being a metal on metal bearing, which sounds like it would be rough and squeak, but actually it's very smooth and very durable. This may allow patients to be a lot more active, and it's designed for that young, active patient. For example, I have a gentleman who's in his late 40s, who's a nationally ranked singles tennis player that had this procedure done and was able to maintain his standing. There are some concerns about this technology. There have been a few reports of problems with the metal bearings. Some patients are allergic to metal bearings, and if they get a wear reaction to this, it can cause pain and swelling and dysfunction of the joint. So we're conservative about using this. It's a promising new technology, but there's still some questions out there.
What is the composition of the metal, do you know?
The metal is a chrome cobalt alloy. And it has to be that way because titanium is a soft metal that is not designed for a bearing surface. It's very strong, but it's not hard.
Okay. Now, is there anything different between the longevity of these and the total joint?
Theoretically, this metal-on-metal bearing may last longer, but we don't have studies to prove that yet. We have laboratory studies that show lower wear, but it's a little bit up in the air, and I make sure patients are aware of that if we're deciding to proceed.
All right. Now we're going to talk a little bit at the end of this about what is frequently called minimally invasive surgery. Everybody's heard about minimally invasive surgery, particularly with the introduction of laparoscopic procedures and so forth. Where are you in orthopedic surgery with this?
That's a big hot topic. Everybody that comes to my office wants a minimally invasive operation with a 1-inch incision, and that's not always possible. Our philosophy is to make the incision as small as we can, but to make it big enough to do the job correctly. And the way I look at it is, we're trying to put in a prosthesis that's going to last the patient 20, 30 years, we hope. So what if they get out of the hospital a day later because their incision is a little bit bigger? You want the carpentry work and the surgical job to be done properly and not have the implant loosen or wear out. We see cases of surgeons trying to do a big operation through a tiny incision, and they do a poor job. They put the prosthesis in inappropriately and it fails.
Has anybody attempted doing any kind of robotic surgery?
There was some work with that. What we're doing now is a lot of preoperative computer guidance where we will have a custom prosthesis made preoperatively using an MRI scan that will fit the patient potentially more accurately.
And that, I understand you send your scans to the company and they customize the joint.
That's correct.
Is that correct?
Correct. And that's also promising, but as yet unproven.
Unproven. That's very good. Well, I think we've covered a lot of very interesting topics, and I want to thank Dr. Simmons for joining us today. I hope everybody understands a little more at the end of the session than they did before, what the indications for surgery are, what the surgery is and what the complications are, what we try to do to prevent the complications, and what's coming along as new procedures, hopefully down the line. So we thank you very much for joining us.
My pleasure.
We hope to see you again sometime for some other procedures.
Absolutely.
Thank you.